Cool. Very good. So today we're going to be doing two things. I have these two PowerPoints, and we're not going to go through all of it. Effectively, this is more of the anatomy portion of joints, and I'm going to end before I get to the knee joint. I'm going to say the knee joint and arthritis for Friday, because those are the two, to me, maybe the two major topics that we're covering in this chapter. So I'm getting kind of the other stuff out of the way, if you want to think of it that way. Note, 2 weeks from today, exam. I'm thinking the exam, there's going to be a limited amount of joints are going to be on. I'll tell you a question set up coming up very shortly that will be on it. And I'm thinking it's 55 to 60 questions tops, similar format. If I'm ambitious, I'm in a good mood, which depends on what happens tomorrow night, sometime between 8 and 11. My mood will be determined by that. I will start to get those review recordings ready. Start. So try to get you all prepped. And you have 2 weeks. And since effectively as of this evening, I guess by 8, guess what? Everybody's done with lab, right? See, I know. You're excused tonight if you want to go out and get crazy. Yeah, whatever the appropriate expression is today. Okay. That's right. I just got off the phone with my son, who got a great job offer today, and I would say this is my response to him as he described that to me, because he's negotiating. And I said, do me a favor, don't blank it up. I said, as a dad to a son, who I'm so fond of, you know what? It's one of those wonderful father-son conversations that I'm prone to have. Nevertheless, here we go. So this is the most confounding thing about this whole unit. Okay? He's got this all upside down. Whoever or she's got it all upside down. I'm not trying to trivialize people who put a lot of time and effort into making these things or be overly critical. There's an anatomy perspective and there's a clinical perspective. There's a lot of stuff that you learn in anatomy and physiology that when you transfer it to a clinical setting, a hospital, a doctor's office, clinic, whatever, however if you're involved in the healthcare, it's all different. And so people have an understanding. So a lot of what you learn in traditional anatomy, and things like origins and insertions, they're passe. They're not we don't even think of it that way, because we understand, we have a much more sophisticated view about how things move and how things work. So number one on the hip parade, the single most important thing, not a minor role, is the shape of the joint. That's the absolute single most important thing that has to do with it. It determines everything about the joint. Its inherent ability to function is all about the shape. And indeed, its stability is all about its shape. And you're going to see, and I mean, it's just, shallow surface is less stable. It is not a minor role. Ligaments play an extraordinarily major role, not a limited role. Yeah, the more ligaments, the stronger the joint. Boy, master of the obvious. Okay. When you hear the term ligament, there's a lot of connotations. These are musculoskeletal joint-related ligaments. You hear the term ligament in other contexts, it's not the same. So sometimes they paint a bit with a broad brush. But nevertheless, we dissected away all the muscles from a lower extremity, from just above the hip all the way down to the foot, and it stood up by itself with no muscles whatsoever. So the muscles play a comparatively minimal role in a lot of structures. The integrity was assured by the structure of the joints and the power of the ligaments that were there. Is that true of every area? No, maybe not. But about the muscle tone probably is the single most important thing when we're dealing with the shoulder. With regard to the arches of the foot, whoever did this has no idea about the mechanics. So understand, it's not I'm going to ask you questions about this stuff. I want you to understand that there are pitfalls if we just look at things and you don't analyze them. So when you're here, you're learning anatomy and physiology textbook-wise. It's a whole lot different than what we see being utilized in a clinical setting. They have a lovely couple of charts about all the different joints. Depending on where you're going career-wise, this may be of significance to you. It may not be. So it depends who you're going to use it. So, I mean, that's what I mean. And you can see from the way I'm discussing this, I'm not going to ask any questions about this. I'm going to focus on specific joints if there are any questions, and really the categories of the joints. This is the origin and insertion. In traditional anatomy, when you learn muscles, okay, you'll learn the origin, the insertion, the action, blood supply, and nerve supply. That's tradition. Okay, we did that years ago. Today we look at attachments because origin insertion, this idea of immovable versus movable bone, really is ludicrous when you think of the way we use the human body. I mean, if you go to the gym and do curls, okay, so you're going to do curls with that. Okay, flexion and extension. This, okay, theoretically would be the origin. Here would be the insertion without going to the anatomy, radial tuberosity and blah, 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 all that type of stuff. Biceps brachii and the brachialis. Fine. But what happens if you're doing chin-ups? Now you got done with curls, now you're going to do some chin-ups. It's working the opposite way. Okay, this becomes the stable point, and then the body, the arms, and so be it because of their attachment to torso, becomes the movable point. So you flip it. You flip origin and insertion. That's why the term attachment. And sometimes they're proximal and distal, sometimes they're superior and inferior, sometimes they're medial and lateral. It doesn't matter. I'm not going to ask you about all those things. But I want you to understand how much this differs from what we look at things. And so muscle contraction causes, if you want, the relatively fixed point, the relatively movable point, to move toward the more fixed point, if you want to describe it that way. And there's different ways that it moves that are there. So, I mean, that's, in my view, you could do, if I was in the lab, I teach the attachments and you figure out how it moves because you know what the position is. The deltoid muscle, big muscle over here. Spine of the scapula inserts into the deltoid tuberosity on the humerus, and obviously it's going to lift it up this way, and you're going to see that's a frontal plane motion. Indeed, the next part is all about different motions, and everything is the context. And this is anatomy class. This is the lab. In the anatomical position, first thing you learn when you walk into the lab, this is the first thing I would always teach. Here's anatomical position. So we look at planes: sagittal plane, flexion, and extension. Frontal plane, coronal plane, abduction, adduction, away from the midline towards the midline. That is because it's in the frontal plane, and you notice the way I said AB and adduction. Because when you add an abduction, sounds the same. So when you have two words, even though they're spelled differently, that sound very similar, you have to seek in a clinical setting when patients' lives are potentially at stake, where injuries to patients are at stake. You always have to use very, very distinctive ways of pointing that out. So I say abduction and adduction. Can't make a mistake. When we get to the nervous system, you're going to hear about afferent and efferent. You could look at this, but if you look at it, you say, well, that's afferent and efferent. You emphasize the A and E. Afferent is an incoming signal, sensory signal. Efferent, think effector, effects the change, goes to a muscle or a gland. So, and this is in this terminology, you're going to see this again and again. Okay, when you look at the anatomy, so it's good to be familiar with it now. And so when you're talking to somebody else about what's impacted, phrase it the right way. It eliminating confusion is a big deal when there's sick people or injured people hanging around. Avoid errors. So that's why it may sound silly, but it's also keep it simple when you're doing stuff like this. So those are the major motions. You're going to see the illustrations in this PowerPoint sequence. Understand, we think of things moving when we talk about an axis. So you just saw me do it. Sagittal plane, flexion and extension. Frontal plane, AB and adduction. Transverse plane, rotating inwardly and outwardly. What if it doesn't do that? What if it's something different? They call those non-axial movements. So a non-axial movement involves those tiny bones in the wrist And in the ankle, the intercarpal and intertarsal bones, it involves the superior and inferior articular facets in the vertebrae. They just subtly shift a little bit, side to side, up and down, tiny bits of motion, but they're additive nature. All of those bones and all of those joints equal a fair amount of motion. Think what you can do with your wrist. And if you're rolling it around this way and this way, you have so many ways you can contort it and move it. Think of what you can do, all the twisting that you do when you're doing an exercise or you're working out or you're just working around the house and you get into some wild contorted positions trying to go reach for something. That's the beauty of all these small joints working in concert. So a tiny bit of motion at multiple areas yields a lot of motion that are there. Those are the accumulation of these non-axial slipping, sliding, gliding. Everybody uses different words for it. If it only moves in one plane, like the elbow, which you will see, we call it uniaxial or monaxial. If it is in more than one plane, index finger flexes and extends, abducts and adducts. That's biaxial. It doesn't always have to be those two, but typically it is. For instance, in the knee, you'll see it flexes and extends. And if you did not know, just watch somebody, you're seeing a track meet, or you're watching, a competition on TV, or something like that, and you can study their legs. When your heel strikes, your knee bends just a little bit. If you watch it, the knee rolls internally, medially or internally rotates, just a smidge. That's an unlocking action that allows forces to be transmitted. When somebody's like in a cast or a brace and has to walk straight right ahead, I really doesn't like it. Forces aren't transmitted. So there's a lot of this that's involved in mechanics. A lot of the students in these classes, maybe there's some folks in here, or in the biomedical engineering division. We have a really fine department with that here. There's a lot of stuff. This is where it comes from, understanding the mechanical aspects. I have a pretty substantial background in biomechanics, and my affection for loving sport but not being terribly athletic, to be kind. Whereas my wife said to me yesterday afternoon, coming and going, "Is that game? What game is that? Is it over yet?" And I knew just what to do. I'm watching the Italy-Israel World Cup qualification from wherever they were playing it in Udinese, Italy. So all of that. And then the classic multi-axial has its own special movement. It's called circumduction. It means just by isolating your hip or your shoulder, you can take your index finger or your big toe, whatever, and you can trace a circle. So effectively, the motion is somewhat conical. Fixed point here, tracing sort of a wide conical structure. And it's not quite the same. You can kind of do it with your index finger, but it doesn't really rotate the way. So the only true joints that are multi-axial by definition are the hip and the shoulder. Those are your only two ball and socket or multi-axial joints. And indeed, their motion of activity is called circumduction. And so this is where it is. So gliding movements, okay, shifting, sliding, angular, flexion, extension, AB or adduction, and then rotation. And in anatomy, they call it medial and lateral rotation. In the hospital, we say internal and external. Orthopedists are the ones who use that term all the time. Orthopedic surgeons strictly say internal and external rotation. They look at you funny if you say medial and lateral rotation. So the fact, we learned that in anatomy class. Listen to what other people are saying if you're in a clinical setting, and that's going to be the vernacular that you will use. Because you have to be able to talk to them in a language that they understand. It's more of you're not trying to make them understand, but you understand, you have to talk to them that way. So again, intercarpal, intertarsal joints, the again, superior and inferior articular processes of vertebrae, those are these, and we add their actions together. So all of that, those 8 bones, they're so interesting. The problem with them is they're all short bones there. I mean, I know the vertebrae are right. Short bones have a lot of cancellous bone, and they have cartilage all over the place. And that means when they're injured, if somebody falls, and there's real trouble when an elderly person falls, because things break fairly easily. And then all of a sudden you have multiple joints that are affected and rapidly can become arthritic. And it's so hard. It's so important when we deal with folks like this that we try to get to these things early, try to immobilize it in a position where it's going to heal the best it can. And then you have very, very aggressive physical therapy, very, very aggressive occupational therapy if necessary. What's occupational therapy? How's it different from physical therapy? I had a student who knew about occupational therapy. Because a lot of the students who are going to the health sciences area of occupational therapy is one of the courses of endeavor. I'm not expecting you to know it. I was very pleasantly surprised that this young lady knew that answer. Yes. Perfect. You got it. I'll tell you the phrase, ADL, activities of daily living. Everybody learn that. Somebody's going to ask you that question in a different setting, whatever your major is, and they're going to look at you and you're this person gets it. ADLs. Nothing is worse when you can't do these for yourself. Go to the bathroom, take a shower, wash your hair, comb your hair, get dressed, shave. Okay, any of those are the activities of daily living. We take them for granted because we can do them. When you can't do them, it is horrible. It is so, and particularly with older folks, it really takes them downhill in a hurry because there's almost a sense of freedom. It happened to my mom when she ended up falling and fell once and then fell another time after it. And all of a sudden, she went from an 86-year-old lady who could drive back and forth from Rochester, New York to northern New Jersey, 6-hour drive with one stop by herself, to somebody who couldn't, all of a sudden was starting to lose these, and your mental status declined. It was an absolutely true story what happened to my mom, who was extraordinarily independent until a relatively elderly age. And a lot of people drive when they're in those late 80s going on. So, and they really get you. And if it happens to somebody you know, when they're confined to do those things. So occupational therapy, they really have an expertise in upper extremity because that's really the framework. You don't do those things too much with your lower extremity, but they'll learn to use their hands so they can do things at home, make dinner for themselves, get up, find ways to help take a shower or whatever, get dressed. So it's really important. That's what occupational therapy is. I taught, 20 years ago, I was teaching some of the masters. The degree was master's in OT at Chatham, right, which is where for 5 years I worked there before I came here. So really important. That's where and they really go into the anatomy in a much greater depth. So if you're heading in that kind of a field, physical therapy, occupational therapy, physician's assistant, and nursing, it's a whole other subset of things that you learn. A whole other subset. Because then all the nursing parameters come into play. So you'll see. That's why I'm trying to give you an idea of what this is about. So here they are, pretty straightforward. Flexion and extension. Some joints are designed to go past it. All those wonderful gliding and sliding joints let you flex, let you extend, let you hyperextend your neck, your back. But your elbow and your knee, you can't do that with because typically there's some type of typically bony opposition. So if you hyperextend a knee or an elbow, someone's got to give. So either you're going to tear something in soft tissue or you're going to tear something in the way of bone. You might induce a fracture. So that's why you see those in, and you see, so a couple on the football field. I saw Roethlisberger take one, his knee went backwards. But he was such basically a defensive end playing quarterback. It didn't matter. He just give me something to bite on and put it back in place and tape it up and I'll go back and play. So here you can see these things. God bless her. Text from a higher authority. Boy. So here you can see these things that are there. So you can see flexion and extension. And so and here's that hyper. So I mean it applies to the same thing too with the upper extremity. So this, your pectoralis major, if you didn't know, flexes your arm upon your torso. The latissimus dorsi opposes it. It extends your arm upon your torso. So flexing and then extending, taking it back to neutral. So it's designed for hyperextension. You can abduct, abduct, or you can adduct, and you can even hyperadduct. So we don't do this very well. Same thing with your legs. You probably don't go over. So some things you can do, but they're not a natural movement. You might do them for something unusual is happening, but not so much. So here you are. Here's the circumduction. The limb describes a cone in space, or it traces a circle, like I said. And then rotation around its long axis. That's why they talk about internal and external as opposed to medial or lateral. It sort of depends on what you're looking at, what part is rotating. So medial rotation toward the midline, lateral rotation away from the midline. So we say internal and external, I think, are better examples. We're going to look at this. This is a very interesting joint. There are two joints in your body that are what are called pivoting joints, which is something you would have to know for the exam. And we'll get to because there's 6 classifications of joints. One is the head of the radius and the radial notch. So what does that allow you to do? Hold your elbow at 90. It allows you to pronate and supinate. That's a pivoting joint. It just goes effectively in a transverse plane, if you want to think of it that way. The other one is this, C1 and C2, the atlantoaxial joint. Remember, you have the atlas and the axis. So atlantoaxial is a fancy name for it. And you remember the axis, the atlas is sort of like a ring of bone. And the axis looks kind of similar, but it's got that thing sticking up called the odontoid process, or dens, because it looked like a tooth. And it kind of sticks like there. And what does it do? Because the atlas is the one that's firmly attached to your foramen magnum and the occipital bone, and lets you rotate your head in the typical no motion. Those are the 2 pivoting joints. Only 2. And so the classification is important from an anatomical perspective. Here we are, rotating, whatever you want to call it. And then here are the special movements. Supination means palms up, or something up, face up, palms down, face down, pronation. If you have a patient who is supine, they're laying in bed and they're back. If you have a patient who's prone, I found him prone on the floor or her prone on the floor, they're on their belly. So those are important terms. When we start a surgery, patients start in a supine position. If we're going to have to operate on their back, we don't start them on their back because it's all about the airway. So if you're going to go into anesthesiology as a subfield or a CRNA, a certified registered nurse anesthetist, what happens is you start everybody on their back. You intubate to maintain the airway once they're asleep, and then you flip. Maybe you flip on your side. We do fractured hips on the side, backs, whatever you're accessing the back. So if you didn't know that, that's kind of how it works. The whole idea is you have to maintain the airway, and the only way you can maintain the airway without intubation if they stay on their back. Fortunately, my patients were basically like that. Sometimes for very long surgeries, we intubate anyway to maintain the airway. And then we have special terminology. We use the term supination and pronation in the foot. If the foot's kind of flattened out, we call it a pronated foot. If it's very high arched, supinated, and you can mimic those motions. By the same token, we specialize it for clarity. So if you're stepping on the gas, now it's called plantar flexion. We used to call that extension. If you're bringing your toes up towards your nose, that's dorsiflexion. It used to be called just flexion. So a lot of these over the years have been done to clarify the particular motions. And if you get somebody who's old school, really old, I don't think you see it now in the hospital. I did. For people who were, I got their degrees in the 30s and 40s. They used older terminology. And then, remember I showed you an inversion sprain, sole up point in the midline to roll your ankle along the outside, and eversion is the opposite, rolling it on the inside. And then the jaw movements, protraction and retraction, which we'll get to because we're going to talk about the temporomandibular joint as we go forward. So there you can see inversion, sole toward the midline, eversion. Typically, eversion is a problem. That kind of sprain jams the talus into the ankle. That usually is accompanied by bad leg. And then jaw movements, protraction, retraction, etc., etc. Elevation and depression, particularly about the jaw. I mean, who cares about shrugging the shoulders? And opposition is very specific to the thumb. And so that's where we're coming to all this. I don't know. Well, every time I do this, I didn't tell the other class. My 7th grade gym teacher, not brilliant. He one day coming, you know what makes the difference between you and a monkey? You can do this, the monkey can't. Little did he know, a lot of, I hate to use the term monkey, a lot of members of that sort of category or family of the animal kingdom can do that. It was wrong to start with. But boy, I mean, they weren't very bright. Didn't I tell you about the difference between the gym teacher and the janitor? I didn't. Khaki pants, some kind of like pullover shirt, the keys. 6,000 keys. The whistle. The guy with the whistle. That's the whole difference. He never knew. Are you the janitor or the gym teacher? I wasn't very fun. Stein, listen up. You said listen up. If you said listen down, I would have done this. Take a lap. Oh, where should I take it? I was that. I had my own chair with my name on it in the principal's office. That's who's teaching you. The obnoxious kid who sat in the front row and the teachers begged to be absent. What goes around comes around. Cheating, I wrote the book on it. I developed methods. But I didn't have to cheat because other people, they used to isolate me. I went in college. I was like, please sit up here. Go sit up by the blackboard. Nobody else was. Why? Terrible. Okay, here's a test question. Everybody get ready. Think of this as the answer key. It'll be one of these 6 terms, 5 of these 6 terms rather, labeled A, B, C, D, and E, whichever 5 I use. And so you'll have to, and I will name the joint, and you'll have to say, aha, letter A is plain, letter B is hinged, etc., etc. But what makes it easy, there's a lot of limitations. Plain joints, intertarsal, intercarpal, the vertebra, superior and inferior facets, those joints. That's it. They're limited. I'm not going to say trapezio-trapezoidal joint. I'll say intertarsal. I'm not going to say talonavicular joint. I'm going to say intertarsal. You just got to know where the bones are. You should know that. Hinge. The best true example of the hinge is the elbow, and you'll see that anatomically in a minute. The only other ones are proximal and distal interphalangeal joints. Anatomically, they don't permit, like I can do this. This is a metacarpal phalangeal joint. You'll see that's a condyloid joint. These guys just up and down. Okay, and they involve proximal and middle, or middle and distal phalanx. It doesn't matter whether it's on a finger or on tongue. Pivot. There's 2. I just told you. C1, C2, atlantoaxial joint, and radial head and the radial notch, which is the proximal radial ulnar joint. By definition. You'll see that in a second. There are many condylars. Best examples, the knee is one, metacarpal phalangeal, metatarsal phalangeal. Now you'll see the illustration. Saddle, there's one. Slam dunk. That's the base of the first metacarpal with the trapezium. Remember the 8 main bones? Trapezium, trapezoid, those guys. Capitate, hamate, all that. That in the base of the first metacarpal trapezium is exactly a saddle. The trapezium part, and you'll see the illustration, is the saddle the first metacarpal base is sort of like the reverse of the saddle, and that's what allows you to oppose. And there's only two ball and socket joints, shoulder and hip. Not so complicated. So here they are. So you can see different shapes determine it, carpals, metatarsals, etc. Flat surfaces, and these are mostly flat. Shift. Hinge. See, this is, remember what's the name of that surface is? It's called the trochlea. A trochlea, or a trochlear surface, it's not the only one in the human body. Okay, there's actually one, the talus, the dome of the talus is somewhat trochlear as well. What that is effectively a pulley shape. So a pulley, if you're in physics or you had physics, a pulley basically is sort of wide and narrow in the middle. And look, this is the reverse of it. You have that ridge in the trochlear notch that effectively, literally and figuratively, does not allow any wiggling room. Okay, so it's pure, effectively, the trochlear. So the humerus and the ulna is very much the best example of flexion and extension, something that's monaxial, where the interphalangeal joints, distal and proximal interphalangeal joints, are part of that as well. Pivoting. You don't have the atlantoaxial and rotating around the dens or odontoid process, but here you can see the head of the radius and the radial notch. That's the other pivoting joint. Allows you to supinate and pronate. There are an abundance of condylar joints. The condylar joints are defined by something that is, very convex. The convex is against a concave surface. Even though it favors flexion and extension, it allows a certain amount of AB and adduction. So you're moving in two planes. The knee is slightly different because when you step down, the fact that you have, when you flex the knee as you make contact, what it does is it allows a certain, because of the menisci, fibrocartilages, and we're going to look at the knee in some length on Friday, allows a certain amount of internal rotation of femur on the leg. So if you watch somebody's knees when they're running, you can see it. Or walking. So that's biaxial. And the saddle, this is it. Base of the first metacarpal, trapezium, pardon me. And you can see that. So it's a saddle, like you have a saddle on a horse. And the ball and socket joint is pretty self-explanatory. That's the hard stuff. So, and with the time we have left, I'm going to go through the examples, the 4 different joints, not the knee, and go from there. For that, go on here. This is the next part of it. There's a lot of nuances. These are joints that have certain degrees of complexity. I'm saving the knee because it's the most complicated joint for next time, because it's got all degrees of complication. The jaw, remember I told you about the attachment of your upper extremity to your appendicular, your axial skeleton in the upper extremity, one location, sternoclavicular joint. It's all about motion. Part of that motion is enabled or facilitated by a small cartilaginous disc that's in here. Fortunately, this pretty much resists. There aren't a whole lot of injuries into that area, fortunately. Not so with the temporomandibular joint. The temporomandibular joint is another joint that has a cartilaginous disc. The more degree of complexity, if you take a simple joint, let's say like the elbow at that particular area, it's relatively straightforward. When you start putting things in the joint, like additional ligaments like the knee, or cartilaginous discs like the knee or the temporomandibular joint, that's more stuff to go wrong. And therefore, and it's more stuff to go wrong, and it's more difficult to heal in the process of doing that. That's what, from a clinician standpoint, simple things are fairly easy to deal with. But when you have extra things in there, they create complications. It's like taking a patient that you're trying to manage, and we call certain patients who are problems. This is a management problem. It's not about labor and management. It's like you have so many other factors in there. And I mean, there's so many different things. Oh, he or she's always a complainer. They can't tolerate 3 medicines they really need to take. They're constantly moving around. They're not compliant. Management problem. Multiple diagnoses. The last thing you want is management. So jaw joint is a modified hinge, hinging sagittal plane up and down. So we call it elevation and depression. Fine. Effectively, it's flexion and extension, just named differently. The mandibular condyle and the temporal fossa, which is a comparatively shallow area that's there. What secures it is an extremely strong ligament, but it's only on the outside. So it keeps it from, it allows enough motion because of that cartilaginous disc to move side to side, forward and backward. But what kind of tries to keep it in place, that whole assembly, is this lateral ligament. And again, the architecture of the joint, remember that first point that they made before. Oh, that doesn't, the shape of the joint doesn't play that big of a role. Yes, it does. So, and what that cartilaginous disc allows is side to side, sticking out your jaw, pulling it back in. So all of those things are so integral to chewing and biting and speaking and facial expressions, have problems associated with them, particularly associated with injuries and your bite. And that's why, here we go. Back in the day, dentists didn't even think about it. When I was a kid, you're just, cavities, this, that, straighten out your teeth, you really need orthodontia, blah, blah, blah. And then bite started to become relevant as we began to see problems with the temporomandibular joint dysfunction and problems associated with sleep apnea. A lot of this is related to the same problem. It's the most, as you notice there, it's the most easily dislocated joint in the body. So there's more problems that have it. You probably know somebody who has it. It's not particularly pleasant. They might have to wear a device at night, not unlike what sleep apnea patients do. They might have a bite plate. I know my wife had one of those, which was a separate condition, but still she would have to use that under certain circumstances that were there. That's the most easily dislocated joint. What's the most frequently fractured bone? Little toe? Baby toe? Anybody? Clavicle. We have a winner. God, if we get the answers right, I am very happy. Everybody's getting it's like my grandchildren. We're going to get a star today on the calendar. They bribe. That stars add up to money. You're teaching the kids early. They have a bigger bank account than I do. You don't want to see me in next fall. There's a good chance they're going to be living in Bahrain for 2 years. Not fun. An island in the Persian Gulf is probably not grandma and grandpa, unlikely visitors. Okay, so easily dislocated joint. It typically, and it's not easy to put back in. That's not something people should try on their own. That's the kind of thing where you take them to an emergency room. Again, not a knock on urgent cares, but there's certain things that need to go to emergency room. Because people are much more likely to have been more familiar with these. Because typically you go to urgent care, you better go to the emergency room. Because you have to sedate them. We use intravenous Valium or intramuscular Valium injections. So here's the lateral ligament. That's what holds everything in place. Here's that cartilaginous disc. Again, problems occur because of these, anything extra. Anything that simplicity, there's an elegance in simplicity. Complications come from more complicated anatomical structures that are there. And you can see some of the illustrations. Most common because of the socket of the joint. Dislocates forward anteriorly And I get, and you don't want to start pushing things. There's a whole. Did you learn about the facial nerve in A&P? Cranial nerves? What's on that? Okay. The stylomastoid foramen is directly adjacent to the temporomandibular joint. The facial nerve that allows you to move all your facial muscles is from there. Problem is, you can mess things up if you don't know what you're doing. Never try to do something because, if you don't know what you're doing, the single most important word in healthcare, help. Experience is a great teacher with things like this. These things that you always ask for help. I don't say it facetiously. Because a lot of things you can do more harm than good. It's really things you have to keep in the back of your mind. When you're confident and know what to do, do it. It's like starting CPR. You do it. As opposed to trying to do something. I read about this in a book. Maybe if there's nobody around for 50 and you're not going to get help for 2 hours and somebody could die, different story. All the different symptoms are here: grinding the teeth, jaw trauma, occlusion of the teeth, irregularities there. So there's a lot of things. The bite plate I told you about. This is the most freely movable joint in the body, the shoulder. It is extraordinarily complex. Of all the joints, this is the one where the muscles play the biggest role. I'm sure you learned about the rotator cuff. I'm not going to ask you to name the rotator cuff. The whole idea is upper extremity. It's all about mobility. Lower extremity, stability. The shoulder has the widest range of motion. You only have that limited attachment for that whole upper extremity and a shoulder that moves extraordinarily freely. Even though you have the same category of motion at the hip, it's all about stability. The attachment of the appendicular skeleton, the axial skeleton, is those auricular surfaces on the ilium and on the sacrum. It's called the sacroiliac joint. Okay? Those two roughened surfaces coming together, surface area. Here you got a little spot. Got it? So from structure, we can determine function. And they compromise. You can't, if you're going to compromise, if you need mobility, you're going to compromise stability. If you need stability, you're going to have to limit mobility. There's no two ways about it. It just don't work that way. I worked on enough bones and joints to tell you that. Sometimes you had to stabilize something because it was a mess. What's going to happen? It's going to limit. Can I play that anymore? No, you can't. Sorry. Not if you want to fix this and take away the pain. Can't do it. So that's a very accurate statement. This is what's interesting because this is not a true socket. Even though it behaves like it's a tiny, you saw the glenoid. It's flat as a pancake. Okay. And so there's very little coverage, even though it has that surrounding it, the labrum, which is fibrocartilage, that means lip. The capsule is relatively weak. It involves, here, for instance, the long head of the biceps in that tendon sheath. It involves the rotator cuff, the three muscles from the back, supraspinatus, infraspinatus, teres minor, and only one from the front. Anatomically, you have the bulk of the scapula posterior, the acromion process, and the coracoid process basically above it. So dislocations are anterior and inferior. There's a whole lot of stuff going on in this. The labrum adds to the depth, but still only 1/3. And these are relatively, they strengthen the capsule, but are weak. So we have mobility. And the exact opposite when we get to the hip. So there's a lot of soft tissue structures combined. They have a degree of stability, but not so much to impede the activity. A lot of bursal sacs, a lot of moving parts that are there. This gives you an idea of the glenoid. This gives you an idea of the labrum. This is the capsule. And again, not a whole lot anteriorly that are there. And so this, you can read through this. I'm not going to ask you about it. If you were in lab, I'd ask you about it. Those would be things I'd have you labeling on a diagram or answering a question. Which one of these which are the four parts of the the rotator cuff, because it's important. You can see how nice the head is. That's there. Common, a lot of things. We used to see a ton of them. Football, a lot of fights and things like that. Our hospital had the city prison contract in Philadelphia. Oh boy, we got some pretty good. We got some really interesting trauma from those fights in the prison yard. You see a quote: "Prisoners are having a softball game. We're bringing down about a dozen of them." Biol. Again, every doctor who's a resident has those kinds of stories. I'm not unique. I was just fortunate to be exposed to them. The elbow rather, very strong and anatomically strong, very held in there very well. These are the collateral ligaments. This, the annular, and annular means to encircle, is the ligament that holds the head of the radius to the ulna. So the radial head and the radial notch on the ulna. The collateral ligaments, either radial or ulnar, are the ones that give the side-to-side stability. Very strong. Hard to dislocate. Okay. And again, this is one of those pivoting joints that are there. And then lastly, the hip itself. This is where the socket is everything. That head of the femur in that deep acetabulum, when you remove that to do a hip implantation. So if you're doing an artificial hip, we did it. You yank that out, the sound would be like you're pulling a cork coming out of a champagne bottle. That loud noise everybody would hear in the room. And it took some force. When I first heard it, this orthopedic surgeon weighed 250 easy, and he's pulling with all of his might. When you work on bones, generally it's big people that do this. So the labrum, really, now you've got about 2/3 engagement. You can see the extent and the excursion that's there. There's the head. This ligamentum teres means round, is more about the vascular supply. It has really very little to do. And the joint is very, very strong, as are the ligaments. And I'll leave you with that. We'll deal with the knee, and we're going to deal with arthritis next time. Thank you very much.